So there is lots of misinformation and rapidly changing evidence around coronavirus and pregnancy. Today, we're going to talk to you about what we know at this point around coronavirus or COVID-19 and pregnancy, and empower you to protect yourself and your growing baby.
If you want more great information on pregnancy, newborn care, breastfeeding, and those types of topics, then subscribe below and check out our website at www.shefoundhealth.ca. Also, please make sure to read our disclaimers below.
So we're still at the beginning stages of the COVID-19 outbreak here in British Columbia. And we as primary care physicians and maternity physicians consider it our job to stay on top of the evidence so we can advise you on how you can keep yourself and your family safe. We want to empower you with the knowledge so you can make the right decisions for yourself moving forward.
So today, we're going to answer the top 5 questions that we've been getting as maternity care providers about coronavirus and pregnancy. Question number 1, should I delay trying to conceive? To be honest, the short answer is we don't know. There's no evidence yet that COVID-19 is associated with increased risk of miscarriage or fetal malformations, but we do know that a high fever in early pregnancy can be associated with fetal malformations. So there's that possible risk, but no clear evidence specifically around COVID-19 infection and miscarriage or malformations. Something important to know and to keep in mind is both the Canadian Fertility and Androgyny Society, as well as the American Society for Reproductive Medicine, have issued similar statements, basically recommending that we put a hold on any reproductive technology. So that includes ovulation induction and any IVF. Another concern that we as maternity care providers have about an early pregnancy during this COVID-19 outbreak includes the possibility of having a miscarriage that actually requires medical or surgical management. The concern there is not so much the ability to manage it, but access to services, as our hospitals could become overwhelmed managing patients with COVID-19. You know, this discussion about delaying whether trying to conceive or not is really individual, and if it's something that's on your mind, you should connect directly with your primary care provider and have that discussion.
So question number 2, is there a risk of vertical transmission? So first of all, what does vertical transmission mean? That means when mom passes a disease to baby while the baby is still in utero, so still during the pregnancy, prior to having delivered the baby. So there's been a couple of studies that have recently come out that originally we thought there was no vertical transmission. That may give an indication that things may change, but there's a few issues with those studies, so we're going to talk about them right now. So there were a couple of small studies done and showing babies who were born who had immunoglobulins. So when we contract a disease, our body makes an immune response and makes immunoglobulins, and that's how we become immune over the long term to a certain disease. We have these cells that remember it, so if we were then exposed, they can go and fight it off. There's 2 different types of immunoglobulins, IgG, IgM. IgG we know pass through placenta. So these babies had IgG immunoglobulins in their blood after birth. IgM, generally speaking, we don't think passes through the placenta, but these babies had IgM antibodies in their blood. So the question is, was there an abnormality with the placenta or something happened at delivery that allowed those to pass through when normally they wouldn't? And the reason we question this is because those babies had saliva and blood tests done showing that there was no virus in them at the time. So we don't know for sure. We don't think that we can pass this on to our babies, but we need more information to confirm that for sure. However, same rules apply. We should be self-isolating as much as possible. Everybody should right now, especially if you're pregnant and you're coming close to delivery. So 36 weeks on, you should be self-isolating. You should not be going out in public. Your partner, whoever's going to be your support afterwards, should be trying their very best to do the same. And if not, when they're coming home, good hand hygiene, cleaning their clothes, trying to decrease the risk of exposure as much. Regardless of whether you can pass this on to your baby, which we do not think you can, we still need to keep you safe during this time.
So the third question we're getting a lot of is, what precautions do I need to take as a pregnant woman? So, it's a new disease and the numbers are small, but as the studies continue to be published, we continue to be reassured that pregnant women do not seem to be at higher risk than non-pregnant women, both at contracting the virus or getting more severe disease. So what we tell our pregnant patients is that you're at no higher risk of getting the disease or getting severe disease than your non-pregnant self. But what it's important to remember is that this doesn't mean that we're low risk. We're just not at higher risk. And this is still quite an infectious virus with a reproductive factor thought to be somewhere between 2 and 3, meaning that for every individual that gets the virus, they're going to pass it at least to 2, if not 3 people. We also know it's got a significantly higher death rate than influenza. So we just need to be diligent to continue practicing good hand hygiene, social distancing, and self-isolation as much as is possible.
So question number 4 is, I'm pregnant and a frontline worker. What should I do? So just as Dr. Sarah had said, we don't think that pregnancy is an increased risk factor for getting COVID-19 or having bad outcomes because of being infected with COVID-19. And as much as possible, we should all be self-isolating, hand hygiene, social distancing. But some of our patients are on the front lines. They're working in the hospitals, whether they're cleaning or nurses or physicians. They're doing all of that type of stuff. And so the recent guidelines are telling us that we don't need to do anything different for those patients. But certainly some guidelines are coming out that we should be cautious in the 3rd trimester. So most of us are practicing that if we have patients who are in the 3rd trimester, they should not be in direct contact with patients who are infected with COVID-19. Now, we think that there might be some increased risk of preterm labor if we have an infection with COVID-19, and that's kind of what has led to that recommendation. And so that's certainly what we're following locally, is if you are in your 3rd trimester, so 28 weeks or above, and you have direct contact with patients of COVID-19, we're going to ask for your employer to move you to a different place, or if that's not possible, we'll take you off of work. Now, obviously, every single situation is different, so making sure if you have any questions or concerns about your particular role and exposure, then talk to your healthcare provider.
So, question number 5, the biggest question we've been getting: what changes are happening at the hospital because of COVID-19? So this is a question a lot of women have, and it's important to know the answer is going to be different depending on where you live. So we can only speak to what's happening where we work locally and the reasoning behind these changes. A question we've been getting is about inductions of labor at the hospital. These are still continuing in the same fashion, and we're still trying to do as many outpatient inductions as are appropriate. So there's no change in that policy as of yet. In terms of when you come into the hospital for your labor and delivery, there are some new restrictions in place. First one is you don't have access to Entonox, that's the nitrous oxide or laughing gas. And the reason for this is the risk of possible aerosolization. So meaning that the disease goes from just being droplet to being in the air. There's no good evidence for this, but there's no clear evidence against it. So what we have to do is what is safest to protect the hospital staff as well as your birth partner. So right now there's no Entonox in our hospitals.
So the other change is there's very strict rules now about how many support people you can have with you during labor. And right now in our local hospital, we limit that to 1 support person. This can be anybody you choose. It doesn't necessarily have to be your partner. It could be your doula. It could be your mom. But we would certainly encourage anybody who you're planning on having as a support person to have been socially isolating for at least 2 weeks prior to coming in with you. The reason that we're doing this is our rooms are not huge, and there's only so much space for us all to stand. And so as a result, the more people there are in the room, then the more likelihood that we're spreading potential disease, because we know that some people are actually shedding virus up to 2 days before becoming symptomatic. And if you've ever been in a delivery before, women are working really hard and breathing very hard during labor and during pushing phase. And so those droplets are actually probably going farther than we think they are. So to keep ourselves safe, to keep our pregnant women safe, and to keep their support person safe, we need to limit the amount of people in the room. The other thing is once that support person comes into the hospital, they cannot leave. So if your support person is a smoker, they may want to get a patch for delivery, because we're looking at 12 to 20 hours that you are going to be in the hospital. Also making sure that when you're packing your bags, you're packing enough food for your support person to have. Now, if you want to check out our link below on a bag packing list, we have that for you, just so you can make sure you have everything you need, because you can't leave the hospital once you come in for labor.
So This is a big concern for a lot of women, and we want you to know that we've taken this seriously, and the decision is only being made based on what evidence we do have. So Dr. Alicia mentioned the concern of asymptomatic transmission, and this is very real. In fact, a study recently came out that 2 pregnant women in New York City came to hospital asymptomatic and later progressed to show signs of disease. Now, they unfortunately became unwell, but that's not because they were pregnant, but because they had other medical comorbidities, and they're now doing fine. But the concern is that they came into hospital with no symptoms, and the staff that were interacting with them had no personal protective equipment, and they interacted with likely anywhere between 15 and 20 staff members. So because we know that asymptomatic, or even what we sometimes call pre-symptomatic shedding, is real and is happening in pregnant women, we have to do what's safest for our staff, our pregnant women, and their partners.
And let's also remember that your support people are extremely valuable to you postpartum when you go home. So your moms out there who've been self-isolating, they can be such a great support to you when you go home. If they've come into the hospital with you, there's a potential that they've actually then contracted the disease and have to self-isolate for 14 days after, which means that they cannot be there to help you for 14 days after your birth. So really, having a support person in a hospital and having an extra support person who can actually come to your house and help you out would be so valuable. But please make sure that that person, if you choose for them to enter your house, has been self-isolating, and everybody in their household has also been doing that.
So the bottom line is, what's safest for you and your partner is to have one support person in labor. I know this isn't something that a lot of pregnant women want to hear, but it's something that we do have to do for your safety and the safety for your family, your new baby, and our community. A lot of women are concerned, but we can tell you this: you will be supported in labor. Our nurses provide exceptional care. I had my 3 babies here, and I know Alicia had her 2 babies here. And I had my husband and my nurse to help me through. And they were incredible experiences, and I wouldn't change them for the world. Another big question women are having right now is, if I have to go for cesarean section, can my partner still go? Right now, the answer is yes. Unless you are COVID-19 positive or you're currently being investigated because you have symptoms, then they would not be allowed in, because the risk of needing to be intubated in the OR and the risk of that disease becoming airborne is extremely high. So right now, if you're not symptomatic, you don't have COVID-19, your partner is welcome into the operating room. That could change. So another question a lot of pregnant women have is, if I deliver and I go to mother babe, can my partner stay with me? So right now, what we've done here in our center is we've converted all rooms to single rooms. So your partner is welcome to stay, but we really recommend minimizing the number of times that they come and go. So we understand that you have a life. You may have children at home, you may have a dog that needs to be let out, but really minimizing the number of times you're coming and going in a day. So make sure when you check out that packing list below, you take heed of the note to pack lots of snacks for your partner, with the caveat that right now you won't have access to a fridge. So if you're gonna bring some things that need to be refrigerated, perhaps packing like a mini cooler, you can access ice at the hospital.
So the other question that we get is, what if my baby is admitted to the neonatal intensive care unit, or the NICU? Can we visit our baby there? And currently the answer is yes. Both you and your partner can come in and visit your baby. However, that might change depending on what's going on in our hospital. We may have to limit the amount of ins and outs during the day, or we may have to limit the amount of people during the day. But certainly at this point, both you and your partner can come in and out of the NICU to visit your baby. Again, we strongly suggest minimizing the amount of ins and outs as much as possible, but it's really important for us that you and your baby are together as much as possible.
So that's it for our update today. Things are evolving rapidly, and we'll keep updating you as new evidence and new information becomes available. We know it may not be what you want to hear, but we want you to know this. We're following the science, what science we do have. We're doing this for safety, for your safety, for the safety of your family, for the safety of our healthcare providers, and for the safety of community. We know it's not necessarily what you want right now, and we know that a lot of you are scared, but we want you to know that we're here for you. We are all in this together.
So we hope that you found this helpful, and we hope that this helps you understand more about the decisions that are being made in your community to keep everybody safe. If you want to know more information about postpartum or delivery, check out these videos here. Check out our website at www.shefoundhealth.ca. Sign up for our email list and you'll get every update that we have coming out sent to you via the email so you can make sure you're on top of it yourself. And have a great day and stay safe.